Good evening and welcome to the annual Florey Public Lecture. We're just waiting for a couple of other people just to take their seats. Fantastic. My name is Josie Gray and I'm the Development Manager for the Faculty of Health and Medical Sciences. I would like to acknowledge the land we meet on, which is the traditional land of the Kaurna people, and we respect their ongoing connection to the land and cultural beliefs. Now it is my sincere pleasure to introduce Professor Andrew Zanatino, who will officially introduce tonight's esteemed speaker, Professor Nick Ward. Professor Zanatino is the Executive Dean of the Faculty of Health and Medical Sciences at the University of Adelaide. He is also a Professor of Experimental Haematology and co-directs the Myeloma Research Laboratory within the Precision Cancer Medicine theme at the South Australian Health Medical Research Institute, SAMRI. The laboratory focuses on identifying the molecular and cellular mechanisms of myeloma disease progression and myeloma-associated bone loss. In addition to his research into multiple myeloma, Andrew is a recognised leader in the field of mesenchymal stem cell biology, and his work in the area underpins the world's largest cell therapy company, Mesoblast Limited. Along with these important scientific and leadership roles, Andrew is a founding member of the Medical and Scientific Advisory Group of Myeloma Australia. He also serves the current chair and as a non-executive director of AusHealth. Please join me in welcoming Professor Andrew Zanatino.
Thank you, Josie. Can people hear me? Excellent. I paid her to say that all for me, so thank you, Josie. And by the way, that is not me. That is the wonderful Howard Florey. Although I must say, I'd probably give my left leg to look like that. He's a very dapper man, you all must agree. Look, thank you, Josie, for that wonderful and very warm introduction. Before introducing our speaker for this evening, I'd like to also acknowledge that we're meeting on the land of the Kaurna people. So, Mani Nadlu Tampinti, Nadlu, Kaurna Yatenga Imparenti. So just an acknowledgement that we are indeed meeting on the land of the red kangaroo, and that we would like to acknowledge elders past, present and emerging. As I indicated earlier, it's really an absolute pleasure to welcome everyone here tonight to the 2024 Florey Lecture. The annual Florey Lecture is, without a doubt, in my mind, a highlight for the Faculty of Health and Medical Sciences. It's a mainstay and been a long-held program which we've run for, I think, in excess of 19 years. 19 years. And it really provides us with an opportunity to share with you, our public, and our friends and our academic colleagues, some of the internationally most renowned individuals in a field of discipline expertise. And that is no doubt the case this evening. As you can see, this is a fairly full lecture theatre, and it really does provide us with a real indication that this is an area of critical interest to you as an audience. As Josie indicated, we're also recording this lecture, so it'll be available to share with your friends and family and to really take on the benefits of what we're going to hear this evening. So this evening's lecture is entitled Lifelong Recovery After Stroke, and is being presented by an incredibly accomplished and internationally recognised professor of clinical neurology and neuro rehabilitation. Could have made that easier for me, Nick. At UCL Queen's Square Institute of Neurology and the National Hospital for Neurology and Neurosurgery. And that person is Professor Nick Ward. Professor Ward is a highly cited clinician researcher and lead of the first dedicated upper limb neurorehabilitation program in the UK. Bless you. His work seeks to understand the mechanisms of impairment and recovery of movement after stroke so that we might optimise both the dose and the type of treatments to improve long-term recovery. Professor Ward trained in medicine at Charing Cross and Westminster Hospital in London, where he also obtained an intercalated degree in neuropharmacology. His postgraduate training in neurology took place at the National Hospital for Neurology and Neurosurgery, Queen's Square and the Royal London Hospital, Whitechapel. In 1999, Professor Ward was awarded the first clinical fellowship in stroke medicine by the Stroke Association. Subsequently, he joined Professor Richard Krakowiak. Is that? I've really messed that one up. Sorry, Nick, and sorry to Professor Krakowiak at the Wellcome Trust Centre for Neuroimaging as a Wellcome Trust-funded clinical research fellow, where he used fMRI to study motor recovery after stroke and conducted work which led to the award of his MD from the University of London. It's going to keep going. I'm sorry, this is just an incredible CV. In 2003, he was appointed consultant neurologist at the National Hospital for Neurology and Neurosurgery, Queen Square, and at the same time was awarded a Wellcome Intermediate Clinical Fellowship to investigate the relationship between post-stroke brain function and motor impairment after stroke. He was promoted to Reader in Clinical Neurology in 2011 and to Professor of Clinical Neurology and Neurorehabilitation in the Department of Clinical and Motor Neuroscience at the University College London in 2017. Professor Ward is Deputy Editor of the Journal of Neurology, Neurosurgery and Psychiatry, and Associate Editor of Neurorehabilitation and Neural Repair. He is co-editor of the Oxford Textbook of Neurorehabilitation and was recently elected Chair of the Scientific Committee of the International Stroke Recovery and Rehabilitation Alliance. I may need a drink shortly, but I'm pleased to say that this is my opportunity to actually ask you all to welcome Professor Nick Ward to the podium to give his presentation this evening.
Well, thank you for that introduction. I've never had to sit through an introduction quite like that. I think it's just a sign that I'm getting old, really. That all those things happen to be listed on there, and it's incredibly humbling. It's very humbling to be asked to do a public lecture, the Florey Public Lecture. It's a wonderful opportunity for me because there are lots of things that I feel quite passionately about in this particular field. And this talk for me, lifelong recovery after stroke, this is an area that I've been interested in for a number of years. I came at it from a very academic point of view, first of all. The idea that somebody could have a stroke, which then left a hole in the brain, and then the hole doesn't fill in, and yet people recover. I thought, that's incredible. Why don't we know more about that? We should. And that's kind of what got me into the field. But I'm a clinical academic, so half of my time is as a researcher, half of it is as an NHS doctor, NHS consultant, which I think keeps me very grounded in both sides. And got to the point where actually the fascination is in the people that I see in clinic, and it's become the case that the research questions come from seeing people in clinic rather than from necessarily reading other people's papers or some idea that isn't really related to their recovery. And just by the very nature of the clinic that I'm part of, that I set up, all the people who've had their stroke maybe certainly over 6 months before. So beyond 6 months is considered chronic. You'll probably hear me use the term chronic stroke. Chronic stroke just means they had the stroke over 6 months ago. But on average, the people that we see in our service had their stroke about 2 years before. But it could be 10 years, could be 15 years. And to hear the stories of people who've essentially been written off and told that no further recovery is possible, not based on any science, is infuriating, and it infuriates me twice a week when I do clinics. So, as I said, I think this talk is really about busting some myths, and I think there's two populations of people that we need to do that for. One is people who've had stroke because they're told all kinds of things, conflicting bits of information that makes it very difficult for them. And then there's the healthcare professionals who are charged with their care. They clearly need to be educated in some of these areas as well. Okay, that's the waffly bit. I didn't plan any of that, but I think putting it in context is actually quite important because we go straight into So I generally, if I'm giving a talk, I assume virtually no knowledge, because that's how I'd like to be treated, because I generally have no knowledge about what it is I'm listening to. So some of you may have experience of stroke, some of you may have personal experience of stroke, some of you may not really be aware of what it is at all. But essentially what we're talking about is a disease. Well, it's interesting actually that there's two groups. You've got the people who think it's a disease of the blood vessels, so they're the plumbers, and then you've got the people who go, but the consequences are in the brain, and that's me, the electrician. But you've got plumbers and electricians in this area. But it starts off being a plumbing problem. So disease of the blood vessels, what we used to call hardening of the arteries, because of all the usual risk factors, can either cause a clot to form somewhere in the blood vessel, or it can cause a blood vessel to rupture. Either way, a bit of your brain is going to get starved of oxygen and it's going to die. Okay, so that's essentially what happens. A bit of the brain dies, and what happens after that to that individual depends on where the damage is. So the brain is just a big wiring diagram. Okay, so it depends which wires are cut and which junction boxes are broken as to what symptoms are caused. But you can think about people suffering from combinations of moving, thinking, communicating, feeling, seeing, deficits of energy, so fatigue is a big problem, and problems with emotion. So somebody could have all of those things, or they might just have one of them. So it's a very complex problem that we're dealing with. And it's a big problem. So this is some information from the World Stroke Organization. And I mean, you can see from the top left, we're talking about 12.2 million new strokes every year. That's one stroke every 3 seconds somewhere in the world. Over 100 million people living with the consequences of stroke around the world, which is enormous. We know it costs a lot of money through various reasons, not just through healthcare, but through people losing their jobs, or people having to care for people who've had stroke and they're not being able to work, for example. But it's the two at the bottom that I think are often the most shocking to people. And the first one is that 1 in 4 adults are going to go on and have a stroke at some point in their life. If you add in head injury, so traumatic brain injury, and other causes of what we call acquired brain injury, which stroke is the commonest, you're getting up to 1 in 3. So 1 in 3 people are going to have, 1 in 3 adults are going to go on and have an acquired brain injury at some point in their life, which is, I find that shocking. And the other thing, which I think is really important for a range of people, including funders and, well, particularly funders, is that nearly 2/3 of people who have stroke are going to be younger than 70. And 70 is is still working age, basically, these days. Okay, so stroke is no longer a disease of the elderly, if it ever has been, but it is perceived very much as a disease of the elderly. So unlike dementia, which is a thing that everybody is terrified of, is a disease of the elderly. And if we make a comparison in terms of the disease burden, we can use this measure called disability adjusted life years. And actually, I didn't know how they calculated it until a couple of days ago. But I think it's an interesting measure. And basically, it turns out, as all these things, it's relatively simple. You take years lived with disability, which is a concept I think we can all understand, and then years of life lost, and then you add those two things together to get this measure, disability adjusted life years. And if you look at the table on the right, you can see that the numbers for stroke are much bigger than the numbers for Alzheimer's disease. Okay. Most of that is driven by the years lost to life, and that tells us that stroke is not a disease of the elderly, that there are many young people who have stroke who will die, and that puts that number up, and so it puts the disability adjusted life years up. So it's a big deal. So if it's a big deal, surely we're trying to do lots of stuff about it, right? There must be lots of funding, the Wellcome Trust, the MRC, they'll be pouring money into this, right? It's such a huge problem. So it turns out not. So total spend on research, this is in the UK. I'm sure things are much better here. Stroke is down at the bottom in terms of the millions spent on research. And a lot of that money will be going on acute stroke, so the clot busting stuff, not necessarily the recovery. The total spend on research per person with the disease, stroke, is also down at the bottom in comparison to cancer, dementia, coronary heart disease. Not to say that those things shouldn't be funded. They absolutely should be funded. Sometimes, academics in particular think of this as a competition. But, if you have to go through the grant process like we do, it actually is a competition. So that's why we speak like it's a competition sometimes. But of course, all of those things also need funding. We should take the money from somewhere else. Okay, so the first key point is that stroke is the major neurological cause of disability worldwide. Okay, but it's being ignored, it seems. Okay, and this is illustrated in a message that was sent to me by the wife of a patient. She wanted him to come to my clinic, and this is what she wrote. They've saved his life, brought him back from the brink, but then they just left him, giving up on him as though he should be grateful to just be alive with no quality of life. Please help. So this speaks to the fact that we have got very good at acute stroke care. So the clot busting, the emergency medical care. So since the early 1990s, when thrombolysis came along, we've got very good at that. Okay? You might almost say that we've solved that problem. We've done it. We're just tinkering around the edges now. But the other bit, the recovery bit, is still neglected. And so I think we're kind of at a bit of a tipping point. Are we going to lean into even more money going into the hyperacute bit? Or are we going to recognize that there's another field? There's the electrics. The plumbing, we're pretty good at. The electrics, we're not so good at. If you go on to what used to be called Twitter, you'll see there's a lot of angry people. There's a general feeling that after 6 months further treatment is pointless and we need to change this. These are all from people who've suffered from stroke. I was told at a stroke club meeting yesterday to give up on physio and accept I am as I am. Believe me, after stroke, the struggle goes on and on and on. And work by the Stroke Association tells us that 45% of all stroke survivors, after they've left hospital, feel abandoned. It feels like the number is more than that to me. I'm surprised it's so low. Those people are interested in thriving, not just surviving. So where does the pessimism come from? Interestingly, it actually comes from the data. So if you look at the recovery slopes that you might have seen if you kind of try and look up some of this stuff, these are some of the earliest that were published. And this is from a very well-respected group in Bristol. And on the left, it's something to do with arm function, and on the right, it's something to do with the ability to communicate, and along the bottom, it's time. So you can see it's in the middle is about up to 12 months, and then what they call the final assessment. So if you looked at this, you'd say, well, maybe they've got a point. There's all this recovery going on early, and then after a while, it just kind of hits the so-called plateau, the word that everybody dreads. And so maybe there isn't anything more to do. And if you look at some of the national clinical guidelines, recommendations about how you should, provide rehabilitation for people, it'll say things like rehabilitation should be provided for people for as long as they are able to participate and they are making change. And you can kind of see how somebody would look at that and go, well, they're not making change there, so we won't offer them rehabilitation. And at first it sounds logical, but it's illogical. It's a completely illogical way of thinking. What was really interesting about this paper is if you read the discussion of it, and these are very well respected back then, still are, but I mean, they're probably not practicing anymore, is what I mean. What they wrote in the discussion, they were surprised by their results. It wasn't their experience that is what happened to patients, that they just plateaued. And they wondered whether the most likely reason for that could be the measuring instruments are at fault, being too insensitive in the upper range, leading to the ceiling effect, or it is also possible that patients are not receiving enough therapy. Okay, so that was 1983. So clearly, as a field, we took that on board, and we did, of course, we didn't, because that's pretty much the same thing that's going on now, right? So we seem to have got into this situation where we think that in the first 6 months, recovery is possible, and then after 6 months, recovery is not possible. And, when I I'm going to say this at the stroke meeting that's going on in the next few days, and probably everybody in the audience will think, no, I don't think that. That's not what I think. But it is the message that is consistently delivered to people who have had a stroke. They all, it seems, have been told their arms are not going to get better, their walking's not going to get better, they're not going to be able to communicate, you're not going to go back to work. So somebody is telling them this. So there is a pessimism around recovery after stroke. So that's what we're here to challenge today. Okay, is it inevitable? Is it a biological inevitability that once you've had the stroke, and 6 months happens, you're fixed? I mean, one awful thing I remember seeing a lady in clinic. She was told she wouldn't have any recovery after 3 months, actually. So she had that day, she put a circle around that day in her diary, and she was terrified that that day would come because she thought she was just going to get stuck in time. And after that, nothing would change. So she was in such a panic because she had to get her recovery in before that date. Okay, so that environment, if you like, made us think that we would set up this particular program. So I'm looking at this through the prism of recovery of movement. As I've said before, I completely understand that recovery from stroke is more than just about recovery of movement, or even specifically, in my case, recovery of arm and hand movement, but that is what I know about. So I'm going to look at the whole problem of the plateau through the prism of upper limb recovery. So about 10 years ago, Fran Brander and Kate Kelly, my colleagues and now good friends, decided to set up the upper limb rehabilitation program at Queen Square. And we see over 400 patients a year in clinic. All of them had their stroke over 6 months ago. So they're all, as I said before, they're all chronic stroke patients. So what do we do? Well, for the ones that we bring into the program, the intensive upper limb rehab program, their timetable for 90 hours of therapy over 3 weeks. So their timetable is 6 or 7 hours a day. Supposed to get 2 sessions each of occupational therapy and physiotherapy, which includes analysis of movement and in functional tasks, as Kate, the occupational therapist, will remind me. We treat them at the level of impairment and then re-educate them in motor control, but always within functional tasks. That'll make a little bit more sense later when we talk about what some of these things might mean. We also have rehab assistants who do some of the things that require less skill and knowledge, like repetitions or putting them on some devices, doing some group work. We work on their cardiovascular fitness, or we show them how they need to work on their cardiovascular fitness, I should say. And then education, self-efficacy, and goal setting are really important components of what we do. I'm just going to go straight to results. So we measure quite a few outcome measures, and as you can see, we published our data in 2019 because we thought it was really important to get it out there. It's not a clinical trial, it's just a report of our service. This is an upper limb measure called the Fugl-Meyer or the modified Fugl-Meyer. It doesn't really matter exactly what it is, but if you've got more control of your arm and your arm is a bit stronger, you'll do better in it. Okay. So what you can see here, so each of these dots is a single patient. Okay, and you can see there are people who are very severely affected, and there are people who are much more mildly affected. So we don't really cherry pick. We bring anybody in that we think we're going to be able to make a difference to. Okay. So the average or the median there is 26 points out of 54. And then they go up to 34, they go up to 35, 37. What you need to know about the Fugl-Meyer score is this. The minimum clinically important difference is 6 points. So if you change by 6 points as an individual, you'll know that there's been some benefit. Okay? If you change by 1 or 2 points, you might not really feel there's been much change. If we look at the actual changes in each individual subject, so this is admission to discharge, admission to 6 weeks post-discharge, admission to 6 months follow-up. This is how much each of them changed. So some people don't change. I mean, this person's kind of ruined my figures here by getting worse. But you can see by 6 months here, about 60 to 70% of people have achieved at least the 6 points. So that's I mean, it's not bad. It's pretty good. It's better than any clinical trials of upper limb rehabilitation that have ever been done. and at much bigger numbers, 224 patients in this. Whereas in clinical trials, you might see 20 patients here, 30 patients there. They don't tend to be very big. This one. Action research arm test is a different type of measure. It's quite dependent on the hand. If your hand doesn't work very well, you're going to find this one hard, and that's why we've got so many people down here with a very low action research arm test. But again, same kind of pattern. They go up most whilst they're in the boot camp, and then after they've gone home, I mean, this is interesting. When we set it up, I had a lot of people say, well, why are you doing that? Why are you setting up an upper limb rehab program? You'll change them a bit, and then they'll just go back to where they were. That was the expectation. But actually, they don't. So they at least maintained, and on average, they continue to improve, which I think is probably the most powerful thing, because this is a sustained effect. And again, you can see about 60 to 70% achieve the minimum clinically important difference for the ARAP, which is also about 6 points. This is a different score. This is called the CAHI. This is much more to do with your ability to do things, what we call activities of daily living, so picking up cups, pouring water from one cup into another, using a pen, carrying a bag up some stairs, so kind of daily tasks, rather than just pure strength or control. Same pattern we're getting, so the bigger changes earlier on and then kind of maintaining, and a lot of people hitting that minimum clinically important difference. As I said, it's not a randomized controlled trial, so we didn't have a control group to say, well, if you don't treat people, they don't change, but we did collaborate with a group from Barcelona who lent us their historical control group of patients who were getting no therapy whilst they did the measurements, and a group who underwent a low dose conventional therapy and low dose virtual reality based therapy, and the high dose, which is us, comes out much better. So there's a dose effect there. So again, we've published the data, 2019. National Clinical Guidelines for Stroke came out 2023, and they were much better for rehab. They made some much better recommendations. The problem, we don't have the workforce to deliver it now, but that's a separate problem. But they described these kind of results, so from our paper and another trial that was done, I think that was in Canada, promising but insufficient high-quality evidence to make it into national clinical guidelines. And this kind of speaks to the kind of vice-like grip that randomized controlled trials have got on the field of medicine and health, which is important. But I think in rehabilitation, we feel like we're being held up to kind of different set of standards. If you have a drug, you can run a trial where you're giving a drug. It's not easy to do it, but it's relatively easy. If you have a complex intervention with multiple components to it, it does become much harder. And the thing about having a randomized controlled trial is you want to avoid the possibility of a false positive, false negative as well, but particularly a false positive. Here's a thing that works, but actually if you really studied it properly, it doesn't work because maybe the control group changes. That's what you want to avoid. But we've studied 224 patients, chronic stroke patients, who are not getting any therapy at all. They don't change. So essentially, I would say that was a positive result. Nevertheless, we abide by the rules. So we are now doing a randomized controlled trial called Intensive, largely run by these three wonderful people. We've kind of snuck a virtual reality-based intensive upper limb rehabilitation in here because it's sexy and it helps you get the money. Otherwise, just testing that against the waitlist control, we probably wouldn't have got funding for that. So 105 participants. We're probably up to about 90-something now, so nearly finished doing that trial. So maybe towards the end of next year, we'll publish something, and then hopefully it can get into national clinical guidelines. What about the active ingredients? So this is kind of more interesting, I think. So what is it about this complex intervention that's helping patients? So we thought about this quite a lot, and I think there's a number of things that's really important for people who are planning services to think about. The first thing is specialist knowledge. You need to know why this man's arm doesn't work, okay? And the answer cannot be, well, because he's had a stroke. Because I could show you another video of a man who's had a stroke whose arm looks completely different. And it's not just that he's a bit weak or is a bit stronger. he's got a different set of problems. Remember, I showed you the list of things that could go wrong. Movement, and just in the arm, you could be weak, you could have increased tone in your muscles, you could have numbness in your fingers, you could have cognitive impairment, so your planning's not so good. All of those things will contribute to you not being able to use your arm. So the expert knowledge is to identify those things, because each of them becomes a treatment target. Okay, so there's no one size fits all. I've got my upper limb, my post-stroke upper limb treatment. That doesn't exist. You've got to say, okay, well, look at this guy's scapula. Look at the winging there. He's got no muscles holding his scapula onto his chest wall. So if his scapula is not held onto his chest wall and he tries to move his arm's going to flop around. He's got no control. It's like having a crane in the ground, but you don't really have any foundations. You try and lift up something heavy, the crane's going to wobble around. It's the same with the arm. So he's got scapular instability. He's profoundly weak. His bicep doesn't work. He can't even get the hand up to his mouth, and he won't be able to let go of that cup. So his problem is mostly weakness, but there might be some other things there as well. So you have to know that, does he have sensory loss, does he have cognitive impairment? You have to know those things. You can't just have, the point about this is you can't just have a generic workforce who do a bit of physio and a bit of OT. If they don't know what they're doing, they're not going to help these people. Second thing, and again, this makes the randomized trials things quite difficult, individualized goals. It turns out that this lady's individualized goal was to chop up a lot of potatoes with a really long, sharp knife. But she, that's great because she likes doing it. And if we get her doing it and we've sorted out her hand a bit with some functional splints and something to get the knife so it's stable in the hand in the right position, she's going to carry on doing that at home. Part of her identity is to cook for her family. She wants to be in the kitchen. That's part of recovery, right? So we're there to help her do it. It's an individualized goal, although cooking is a very common one. The point is, when she gets home, what's she more likely to carry on? Chopping up potatoes and cooking for her family, or following a list of exercises on a bit of paper that we've given her? People don't do exercises because they're boring, okay? But cooking is important. So the individualized goals bit is critically important. And then you can get into high dose, high intensity practice, lots of repetitions. You identify the movement that needs to be trained, and then you do it. But it's not always the same one. It's a different movement for different people. But the principle is the same. And then lastly, promote self-efficacy. So you're giving people the knowledge, the confidence, the tools, sometimes literally the tools, the hope that they're going to improve. So this guy, his goals, one of them was to get back home and start using his own power tools. And he sent us this video after he got home. So all of those four components, I think, are really, really important. And so we don't think of this as a rehab. We think of this as coaching. So if a young Serena Williams came along and said, I want to be the best tennis player the world has ever seen, you wouldn't go, well, there's a racket and there's some tennis balls and I think there's a court over there, Serena. I'm sure you'll do fine. Knock yourself out. You'd provide her with, or she would provide herself with, a coach. They'd do some analytics about exactly how the body moves. What is the wrist positioning when she's coming to hit a forehand? What's her backhand like? What's the foot position like? They'd analyze all of that, specialist knowledge. You'd put that into the actual movement itself. You'd work on her confidence, her motivation. You'd put her into games, and eventually you'd move her up to tournaments. Okay? So it's a complex intervention. It's coaching is essentially what we're doing. So the commonest thing that people say when they leave the program is, oh, I get it now. So remember I showed you those recovery curves and I said, it's kind of interesting that they keep going up. A bit, not a lot, but they go up, whereas everybody else said it's going to come down. I think the reason they stay up is because people go, oh, I know what to do now. It's so common to see people in clinic who are so motivated, but they go, I don't know what to do. I don't know what I'm supposed to do. So we've done some work with focus groups, asking patients what they think the active ingredient of the program is. We also interviewed the therapists who were treating on the program, which was good. One of the things that I really enjoyed them saying was that the expectations from the seniors was very high. Which I thought, good, yeah, it should be. But they were a bit intimidated by that. So these are from the patients and these are from the therapists. So you can think about psychosocial, and the main theme there was that from the patients was you feel valued as an individual. Individualized goals, we've talked about motivation, values and beliefs shared with the therapist, providing them with confidence. And in terms of the training itself, grueling yet rewarding, that's where this term boot camps come from, being pushed to the limits, but enjoying having the opportunity to push themselves to the limit, opportunities to learn. So learning is a really key word here. And the skill set of the people treating them and the resources that we had available. They really appreciated that. From the therapist's point of view, they liked the fact that it was a patient-driven ethos, no barriers, no rules. So they liked the goal setting that I talked about. They appreciated that they felt more confident and independent as practitioners in that service to help the patients, and the general attitude and ethos, which was a can-do attitude. And this one, I mean, this has definitely come from a therapist. It's more than intensity, it's complex. Maybe they'd heard me saying it over and over again, and they were just making fun of me, I don't know. Skilled integrated therapy, so specialist knowledge, integrating between the physios and the OTs, and lots of education about stroke recovery. So what does that tell us? It tells us that in the chronic phase, if we do it right, and we hit people with big enough doses of the right thing, we can make changes. Okay. So in terms of upper limb recovery, I mean, I think for me that's convincing that you can make changes in the chronic phase. But it's still, but there are so, at the beginning we said there's so many people are being told that it's not possible. So why is that? Let's just go back a bit and go, how do we explain the fact that they're recovering? I mean, if it's that simple, you just do some good rehab, then we should have known that before, right? So I think there's three areas that I just want to touch on. One is this idea of plasticity. The second one is recovery of what? And then the last one, very simply, I'll give you a couple of examples that you'll like about dose. But the plasticity one, I think, is important because most people who've had a stroke kind of know the word, and they know it's got something to do with recovery. And actually, most healthcare professionals know the word, and it's got something to do with recovery. But it's really misunderstood, and I think it's actually misused, and it's used in a way to justify the plateau. And so I think that really needs debunking. So I'm going to spend a little bit of time on that. Okay, so this is talking about plasticity, just an excuse to have this fabulous video from some colleagues of mine who do 7 Tesla scanning of human brains, and it's complicated, right? I mean, the thing to take from that is the distinction between the grey matter and the white matter. So the grey matter is that ribbon, that darker ribbon around the outside. That's where all the cells are. That's where all the computing gets done. And the white matter, the lighter bit in the middle, is basically just wiring. And then just coming up, you'll see you've got these junction boxes in the middle, the basal ganglia. So cells doing all the computing, wiring, junction boxes. That's the brain, not that hard. So what are we looking at? So this one doesn't move, so it's easier. So if we look at this box and we expand it, you'll see this is the cortex. So it's this dark ribbon around the outside. That's where the cells are, the cells that do the computing. And if you look at one of the cells, it looks a bit like this. So we're used to seeing pictures like this, very fixed, very static. This is the cell. This is the kind of main trunk, if you like, the axon, that's sending the signals to wherever they're going. And these are branches, dendrites. But if you look in, these are not from humans, these are from zebrafish, but apparently we're not that different to zebrafish. So I think this happens in us as well. This is just an arresting zebrafish. I mean, look how much that cell is changing. It's not doing anything, but it's like it's looking for connections all the time. And that's happening in all of our brains all the time. The brain is looking to make connections. It's all about making connections. So what makes the connection stronger? So this bit here is what we call the synapse. It's the connection between two different cells, 2 different axons. So the signal's going across there. If you have more signals going across, that connection gets stronger. So that's the use it bit. If you have fewer signals going across there, you lose it. So it's the use it or lose it thing. It's all about plasticity. Now, the interesting thing is, you can get the same thing. You can strengthen a connection, even though the same amount of information is going across, if there's something different about the brain environment. So there's an increase in the potential for plasticity. Okay? So even though you've got the same signals coming across, something is different here that makes the connection stronger, or something is different here that makes the connection weaker. And in relation to stroke, actually what happens is after the damage itself, you have a change in the biological environment of the brain that increases the chances of plasticity occurring. Okay? So this increased potential for plasticity here happens in stroke. And I think this is where we're starting to get to this concept of a slope and a kind of flattening off. And it doesn't relate to behavior and recovery. It relates to the biology that's going on in the brain afterwards. Oops, let's go back one. So the term that's often used is spontaneous biological recovery. So in this area, around the area that's been damaged, you see all kinds of changes. So more cells, more potential connections going on, increasing the chances of other connections being made. So, we have to face that and say, well, here's the stroke, increased potential for plasticity, increased potential for recovery. So really, is this the optimal time for rehabilitation? Maybe there is something about this recovery slope. Maybe there is something about this plateau. But we don't really know what goes on here. We don't know whether it goes away completely. The other thing about having an increased potential for plasticity in the human brain after somebody's had a stroke is you've got to be careful what you do with it. Because it sounds good, right? My brain is more plastic, therefore I'm going to recover. But actually, the thing that makes you recover is the thing that you train. And if you train the wrong thing, you'll get good at the wrong thing. So this is an example of work that was done in monkeys. Some pinch grip training was done. And in one group, they were just allowed to compensate. They were allowed to do the pinch grip to get the pellets any old way they wanted, quick as they could. And the group down here had to do it the right way. And the group that did it the right way did better eventually. They got back to 90% of where they were before, whereas the ones who could just cheat, they got back to 60%. Now, what's really fascinating about this is the pink bit there indicates that they got the normal movement back. They had the capacity to do the normal movement, but, I'm not casting aspersions, but they couldn't be bothered, really, because it was harder, and they just wanted the pellet. And this is where they ended up. This really reminds me of patients that we probably all see in clinic who've got no ability to open the hand, which is the holy grail of upper limb recovery, because it's the most difficult thing to get back. And you ask them the question, did you ever have finger movement? And some of them will go, yeah, I had finger movement. It was coming back. And now it's gone. Because nobody did anything with their arm. Because the focus of rehabilitation when you're in hospital is on your walking. And you're maybe not even walking, on your balance and your ability to transfer, because when you can do that, you can go home. And because now we have, certainly in London, almost no community services whatsoever, nobody's going to come in and treat your arm. And so that capacity to move your fingers is gone. The question about that I don't know the answer to is, does that mean we'll never get it back, or do they still have the wiring to get it back? And I hope it's the latter, but we haven't done that work yet. Okay, what about in the chronic stage? So there's this plasticity thing going on early on. So there is an increase in upregulation of the potential for plasticity. So if you do the right training, you should be able to get a bigger effect. It's like turning up the dial. In the chronic phase, there's a few statements that we need to make. So damage to the motor system causes weakness and loss of control, like we talked about, but it doesn't stop learning. So people with just have motor deficits do not have a deficit in learning. That's the first thing to say. So any form of practice that they can do will lead to learning or motor learning through normal plasticity mechanisms, the plasticity mechanisms that we all have. Just normal, standard, common garden plasticity. It's almost not that interesting. It's just what the brain does. The brain is a plasticity machine. It's changing all the time. Anytime you've learned something or you've got a bit better at something, your brain has changed. But the key point is these normal plasticity mechanisms are not time limited. So this fancy upregulation of the potential for plasticity probably is time limited, 3 months, 6 months, something like that. But the capacity to learn and through normal plasticity mechanisms doesn't go away. It's a thing that we all have, right? Having said that, that doesn't mean that everybody's going to get back to normal. Things will be limited by other things. So, for example, if you lose particular parts of the brain or pathways, it may be that recovery of certain things are beyond you. And if you can't train at a particular thing, you're not going to get better at it. So you need a little bit of the movement in order to get better at the movement. But if you have nothing, I mean, it's a huge problem. How do you go from nothing to something in terms of behavior? It's very, very hard. We don't really know what to do in that situation. So I want to show you a couple of patients that we've seen in clinic. So this is Steve. So 2 questions. 1, does Steve have the wiring? Does he have that pathway? Now, he does have the pathway, and I can tell you that because we've done the study on him. We've put the magnetic thing on his head and turned it on, and we've seen a twitch in his muscle. Okay, so I know he has that pathway. Can he train? No, he can't, because he's very little in the way of finger extension. I mean, the big obvious thing is his wrist is stuck in that position, which is obviously the thing that really gets in the way. You can't do reaching and grasping when your hand is like that. But weirdly, that's the most fixable thing. So he's been for surgery on that, and I think he'll be in a position, we get his wrist in a better position, we'll start to see a bit of finger extension, and when we can see that, then we can train him. So we'll get him to the starting gate, if you like. Okay, what about this lady? Does she have the wiring? Yes, she has the wiring, for the same reasons I told you about Steve. Can she train? Yes, she's got voluntary finger extension. Not much, but she's got enough. She's got enough for us to be able to train with her. She can make a pinch grip, probably like a key grip, so we can get her into function. So that's the sort of thing that we would do on the upper limb program. And the key thing about these 2 patients is they've both been told that they don't have any recovery potential because they don't have enough movement. But I think we need to stop thinking about seeing the movement and then understanding actually what's going on in the brain, because that's the thing that would be telling us about the recovery potential. Okay, so early versus late. So increased plasticity. Better make sure you train the right thing. Don't train the right thing. Don't miss fingers coming back because we need to jump right on them. Avoid complications like painful shoulders, which is all too common. I'd say about 1/3 to 1/2 of the people we see in our clinic have got frozen shoulder and have been told, well, you've had a stroke. That's what happens. Frozen shoulder is treatable. It's very easy. It's not a brain thing. It's a joint thing. But it's time limited. And over here in the chronic phase, learning is possible. Normal plasticity might be limited by wiring, might be limited by the ability to train, but that's not necessarily a permanent thing. But it's not time limited. That's the crucial thing. Okay. So the next important thing, and this is probably even more important, is recovery of what? So what I've talked about a lot about so far is the impairment bit, weakness or loss of control in the arm. So that's kind of very, very specific. So to think about recovery across domains, we need to talk about the ICF, the International Classification of Functioning for Disability. So disability is considered to be made up of these 3 things. So a disorder of body function or structure. So that's your weakness or not being able to speak or numbness. Disorder of an activity, so not being able to use a knife and fork, not being able to pick up a cup, not being able to get dressed. And then disorder of participation, not being able to do your job, not being able to fulfill your role as a parent, not being able to do your hobbies.
Okay, all of those are important, right? And if you'd ever wonder what the difference between a physiotherapist and an occupational therapist is, it's not the case that physios do legs and OTs do arms, because it drives us nuts when we hear that. Physiotherapists will approach patients from the point of view of impairment, but then they expect to have an impact on activity and participation. And really fascinatingly, because I didn't realize this until I started to work with OTs, they will come at the problem from the participation angle. What are your hobbies? What work do you do? How are we going to get you back to that? How do we get you back in the kitchen? They expect, or the good ones, expect that to have an effect on activity and then on impairment itself. And that is the whole philosophy of what we do, this kind of bi-directional, going across impairment, activity, participation, and back again.
Okay, but the point is you could recover in any of those domains, right? So let's have a look at some videos of some of the patients that we see. So this is quite impairment-based, right? So we're working on his reach. He's being de-weighted with that thing because when your arm is weak, it becomes very heavy. It's hard to do reaching. So de-weighting, he's now able to train doing a much more normal-looking movement. He's got a bit of electrical stim on the muscles of his forearm to kind of pull his wrist and his fingers back so that he can make a grasp. So then he can do loads of repetitions. So quite impairment-based. This is the thing that you see most in rehab units. People really want to get back to using a knife and fork. It's a really common goal. This guy was lucky. He was given a banana. Mostly they seem to be given this kind of luminous pink gloop. I don't know what it is, and that you definitely should not put in your mouth if you were given it by a physiotherapist. But here we've had to support his hand to get it into the right shape. But it means rather than kind of not being able to pick the knife up, he can pick the knife up and then he can do the whole activity. So here we're training somebody at the activity level rather than the impairment level. This next guy, okay, so this is us being very creative. So we do have some technology. This is a kind of robotic device that de-weights. And this guy's, his personal goal, one of his personal goals was to get back to fencing. Okay, I think he was pretty good at it before, but his arm is really weak. So you can see these wires here. It's a bit like Thunderbirds. Who remembers Thunderbirds? Okay, here's a Thunderbird puppet. His arm is being held up, so he doesn't have to worry about trying to hold it up against gravity. And then he can work on the quality of the movement. Because working on the quality of the movement is different to working on strength. Those are two different things. So our therapists are very creative at using these kind of things. This guy used to be a really good golfer, and it's killing him that he can't get back on the golf course with his mates. So we take them down to the local golf simulator, and there'll be a therapist there who'll be looking at how he's holding his grip and seeing if I can get this guy to get down to the driving range, what can I show him to do so that when he's swinging, he's actually doing some of his rehab. Here's an example from actually very early on. So this is the before and after. Personal goal, obviously, to play the guitar. And it looks quite subtle. I mean, it looks quite subtle at first, but just watch his fingers there. You see he can get his fingers off the fret. So finger extension is incredibly hard. It's the hardest thing to get. And over here, he can't get his fingers off the fret. But now, once you can start to take them off, that makes an incredible difference to him. He's going to go and pick up his guitar because what comes out of it sounds like a tune now. So he's motivated by his personal goal, and he's going to work on his finger control. Perfect. It would be the same if it was a piano, for example. This is a lovely example. So this young lady, she wanted to be able to tie her hair up. Look how useful or not useful her hand is. She's not able to open it. She's just kind of stroking the hair away. And over here, she can really bring that hand into that activity because she's now got access to some finger movement, and she doesn't know what to do with her arm over that side. So that's a really lovely example. And then the last one. So this was
When you're ready.
I don't know, you're going to have to listen to me. An Australian occupational therapist. This lady was a paediatric intensive care nurse. So she's not terribly affected. You might say, well, she can get back to activities of daily living. That's fine. She wants to get back to work. That's how she defines herself. I'm a paediatric intensive care nurse. She's has to be incredibly dexterous. So, we can't take her onto the paediatric intensive care and get her practicing putting lines into babies. But, you can find a doll somewhere and you can kind of mock it up. What they're interested in is processing how she's using her hand, what the deficits might be, if the particular weakness that needs to be worked on so that she can then get back to the function. So we're very happy to take people at very high level because their goals are very high level, especially if it's vocational. She's in her late 30s. She's got to get back to work. And this is not we don't do this, but I did want to also highlight just in this kind of finding out what people's goals are. There's a marvellous organisation that we work with called Rosetta Life who do arts-based interventions. And just a couple of examples, this thing called Brain Odysseys. So the idea of Brain Odysseys was to take people who'd had a stroke, put them together as a group, maybe about 15 to 20, give them a choreographer, give them a composer, give them a musician, give them some dancers, and then co-design a production. So that sounds, it sounds a bit like school play, but actually it was incredibly high quality and it went on tour around the UK. Really beautiful piece of work. But the clever thing that Lucinda Jarrett, who runs Rosetta Life, did was to take those patients who'd been through that process and turn them into what she calls stroke ambassadors. So they are now the people who go out and talk to other stroke patients about the benefits of doing the kind of things that they're doing. And then when you bring more people in and then they become stroke ambassadors, the idea is that you create this army of people who can go round stroke units or stroke communities and try and engage people in activities that they might find rewarding. And this is a bit of an extreme example. So this was a collaboration between Rosetta Life and Garsington Opera. I don't know anything about opera, but apparently it's a big deal. It's like Glyndebourne, apparently, if you know anything about opera. Collaborated with them to put on an opera. So 3/4 of the people in the opera were people who'd had a stroke, and then they had some kind of professional singers as well. And they put it on actually at the place itself. So that was quite impressive. So all kinds of things that you can do in lifelong recovery. So is recovery lifelong? Well, participation. Why would you say you cannot improve at the level of participation beyond 6 months post-stroke? That doesn't make any sense. It doesn't make any sense scientifically, does it? It's just, you could always help somebody. You can pretty much always help somebody at the level of activities, picking up a cup, using a knife and fork, getting dressed. You can always make a difference. So why would you say you're done, 6 months has gone, there's nothing more to be gained? I think the scientific question is more about the body structure function, so the impairment level. Can you get voluntary finger extension back? I think that's up for grabs, and we need to understand more about those individuals and what their pathways are like, and do more of that work. But it's quite difficult to get funded. And I think we've gone the other way, and we've assumed that many people will not improve at the level of impairment. And I think there's a good chance that a significant proportion of those people who've been written off will actually improve if you give them the right treatment. Okay, last couple of slides. So, what about dose? So there's a big thing about, you remember from that first slide that I showed you, the slope, and the author said, well, maybe we just don't give enough therapy. That was one of our remits with the upper limb rehab program, 90 hours of boot camp. That was our inspiration. I just want to show you a couple of examples. So this one, who remembers Patricia Neal? So Patricia Neal was a famous Hollywood actress. She won an Oscar with Paul Newman in HUD in 1964. She married Roald Dahl. And when she was 39, she had a big hemorrhagic stroke during childbirth, I think. And her deficits were mostly, I think, speech and cognitive rather than movement. But when she left hospital, the doctor said to Roald Dahl, talk about paternalistic, the doctor said to the husband, what she needs is an hour a day of rehab. And he, smart man, said, how can an hour a day be enough? And so he, back in their village in Oxfordshire, arranged the neighbours and friends and anybody who could get his hands on to come and sit with Patricia and just engage her for 6 hours a day for 6 months. And after that, he employed this woman, Valerie Eaton Griffith, to run this program. And she wrote this book. And my friend and colleague who works in the same field, Steve Kramer, sent me this book. He said, we should probably read this. So I didn't read it for a while, but then I thought, I better read it. And actually, it was fascinating. She put together a program for what she did with Patricia. And what I didn't know was that story became the basis for what the Stroke Association in the UK did when it first started. It was all about community-based rehab, using whatever resources you could in the community to increase the dose of rehabilitation. On Wikipedia, it says, she pulled through with the assistance of Dahl and a number of volunteers who developed a grueling style of therapy that fundamentally changed the way stroke patients were treated. Now, I don't know where they got that last bit, because it hasn't fundamentally changed anything that we do. If people are not being told to even do an hour a day now. So that last bit is incorrect, but I think it's a good message. And in terms of studies that we do in this field, we always talk about what's the right outcome measure. Should it be the Fugger-Meyer? Should it be finger extension? Should it be? What do you think a good outcome measure is for a Hollywood actress? Oscar, right? So she won an Oscar before she had a stroke. She got back to acting, and she didn't win an Oscar, but she was nominated for an Oscar in 1969, and she was beaten to it by Barbra Streisand in Funny Girl. And I think there was somebody else. I didn't know that until yesterday. There was a tie for Best Actress for the Oscar in 1969, but one of them was Barbra Streisand. But anyway, Patricia Neal was nominated for an Oscar, and it tells you that she did a pretty good job of getting her speech and her confidence and her cognition back together. She got thousands of hours of training and behavioural treatment and rehabilitation. So that is the dose that we're looking at. The other example is a guy called Richard, and I mean that's a shocking picture in its own right, isn't it? Just to see what's happened to him here. So he's had a hemicraniectomy, half the skull has been taken off. The reason being, if you have a big stroke and it swells up inside the head, there's nowhere else for everything to go, and it'll push the brain out through the little hole at the back and it'll kill you. So that's a life-saving treatment. His wife, Fiona Lloyd-Davies, is a filmmaker. So she started filming him within days of him having the stroke, and then followed his recovery and made a BBC Horizon program about it. And he came into the Upper Limb program at one point for a little bit of his recovery. He was he had problems sequencing his movements, and he was a bit weak and all the usual things. So we helped him out a little bit. But what happens to people like this if they don't? He had made no change probably by 6 months. He was still in a wheelchair, wasn't able to stand, wasn't uttering any words. I mean, it's an amazing program. I mean, if you ever got the chance to watch it, you should watch it. I tell you what happens to them, they go to nursing homes. And you're not getting any rehab in a nursing home. So he would have been written off. So they met in Sarajevo, actually. So he worked for the United Nations. He was a soldier in the United Nations, for the United Nations, and you can see all of his medals there. So this was a relatively early on, and this was a little bit later on, and there's a really great bit in the program. One of his goals was to be able to salute. And so when he went to the one of the remembrance services, remembrance parades, there's a really nice shot of him being able to salute with his affected hand, which is lovely. So I saw Fiona and Richard probably about 3 weeks ago, and he is continuing to improve. His movement is great. It's really good. Fiona gets a bit nervous when he goes up ladders to clean out the gutters. And he's probably still a bit impulsive, but he may always have been like that, but he does it anyway. And he hasn't fallen off yet, as far as I can tell. And his speech is coming on. His speech is still improving. Okay, and this is 9 years down the line. Okay, so recovery really is lifelong. So just to summarize, so in chronic stroke, so in the latter stages, we see improvements, we see it in participation, we see it in activity, we do also see it in impairment, and all of these are valuable to individuals, and they represent recovery towards their own individual goals. So really to end on that question, so if all of this is the case, then what is a recovery plateau? Because it feels like there isn't one really. And I hope that I've been able to make the case and debunk some myths around things like plasticity and what happens to people this far down the line that would, if you have relatives of yours that have had stroke, would make you much more positive about their potential outcome. So I'm going to say thanks for your attention, and love to answer any questions if you have any. Thank you.
Thank you so much, Nick. That was a fabulous presentation. There's a bit of an opportunity now to, as Nick said, ask some questions. We have one at the back. While the microphone is being brought up to you, I might just ask you a very quick question, if I may. Clearly, you indicated something that I was absolutely unaware of, and the fact that 63% of strokes occur in people under the age of 70. And many of the people that you showed us in videos were really quite young. The thing that I was curious about is whether there was a relationship between age and recovery, or really the amplitude of recovery in the data that you demonstrated or showed us earlier.
I think one might argue there's a relationship between recovery and comorbidity,
Right.
and in particular frailty.
Right.
If somebody's frail, they're not going to be able to engage in rehabilitation so much, and frailty, I guess, increases a bit as you get older. But not somebody who's in their 80s or even 90s if they're healthy. Absolutely not. The idea that the older brain has lost its capacity for plastic change is not true, really. We kind of think youth is plasticity, elderly is not, but that's really about very young children.
Yep.
That kind of developmental brain where they kind of pick things up weirdly quick is really for the very, very, very young.
Yep.
And people who are generally healthy with good brain health are going to have the same amount of plasticity. Maybe you need to do a few more trials, but you're definitely going to get there.
Thank you. So, question up back.
Thank you. My name's Edith Redden. My husband had a traumatic brain injury, and it was 6 weeks before he went into the rehab unit.
Yep.
His first attempt at doing exercises, learning to walk again, etc., he was really excited to get doing that, but they would only let him do a very short time, then they'd make him rest for 23 hours a day. That went on for a bit of a while, and I'm just curious to know, after what you've just said, especially with that Patricia Neal business of 6 hours a day, do you think that was perhaps a wrong way to treat it?
I think there's a lot of factors that you have to take into consideration. I mean, after brain injury, stroke and other forms of brain injury, people are sick. And so we might say 6 hours a day would be great. I mean, don't forget she had 6 hours a day after she'd come out of hospital. It depends whether people can tolerate it. So we have to take into consideration things like fatigue, for example. But I think your point is right. I think units around the world are set up and work in a way that works for the staff and not so much for the patients. And I would say in general, if somebody was back in bed, they shouldn't be back in bed, they should be sitting out. That's the first thing, to work on their core strength. And they were keen and willing to do more, they should be given the opportunity to do more. There's no question about that.
We have a question at the back. Thank you.
Just quickly, I had a whole heap of strokes, 10 little ones. And then I'm finding that MF is causing a lot of pain. Do you get, I feel like the ability to get better is limited by pain.
Yeah, absolutely. I mean, that's definitely a thing. There are, a number of things that can get in the way of, if we think about recovery as training, whether it's moving, thinking, speaking, you've got to be able to do that training, right? If you have pain, and you've talked a bit about your pain, but we talked about frozen shoulder earlier, didn't we? So having a frozen shoulder is awful. You're not going to be able to do lots of reaching repetitions, when the OT takes you in the kitchen. That's going to be a barrier. Stiffness in the muscles sometimes, not being able to feel. So there are lots of barriers, and sometimes we talk about wanting to get people to the starting line so they're ready for an intensive burst of rehabilitation. So we think about making sure they've got good range in the muscles, treating the frozen shoulder, trying to damp the pain down so that they're in the best condition possible to train. So you're right, there are a number of barriers, and that's kind of what I mean about having specialist knowledge. You have to know that person who's got pain isn't going to be able to train, so don't prescribe them or tell them to do lots of reaching exercises or do lots of walking when they can't do it. You have to kind of peel back the layers and deal with the pain first, deal with the restrictions to get them in the best state possible to do the training. So yeah, pain is a tricky problem, and it needs dealing with in its own right.
Thank you. I just had a question, I suppose. If you're in a position where one of your loved ones has had a stroke, what would you say is maybe the single best way to try and engage them in this concept of that some recovery is possible, that it isn't sort of all doom and gloom? what is the best way to sort of engage them in that when they've been hearing for so long potentially and from so many different avenues that, 6 months is over? Yeah.
Yeah, I think there's two things. One would be knowledge, so it's kind of absolute knowledge about your own stroke and what has happened to you, what's connected to what works, what doesn't work. I think that's important. And then finding something that brings them some joy that can be part of their rehabilitation. The trick is for rehabilitation is for people to feel like they're not doing rehabilitation, ideally. I mean, that's quite hard, but you can imagine that if you find something that you enjoy, the guy with the guitar, if he spent all day trying to play chords, he probably loved that, right? So it's engaging people. We talk about, you've got to, and again, I'm just talking about the arm and the hand, but the same principles apply, I think, to other domains. You've got to get that hand into the game. You've got to incorporate it into your daily routine so that you kind of forget that you're doing recovery. You've got to stop your brain forgetting that you've got a right hand or a left hand, whichever side it is. And that all comes about through engagement and motivation, and the individualised goals, I think, are really important in that respect.
Thank you.
Thank you for that excellent question. I might ask one final question if there is nothing out in the audience.
We just got this lady.
There is? Oh, fantastic. Wonderful. Then you are going to ask the last question. You have got that honour.
Thank you very much. I had a stroke in August, and my stroke has impacted my eyesight and, to a smaller degree, my memory. Most of what I've been reading about brain plasticity has been dealing with your examples of physical, but what about those who have impacts that are not physically visual? So I can't see, and my brain, I'm dyslexic, so I've lost a lot of my dictionary in my brain, but nobody knows that I've got that disability, and where do I go for assistance?
I mean, it's a great point that you raise, and again, we talk about the problem of unseen symptoms. So again, problem with movement, even a problem with communicating is kind of very obvious, isn't it? But if you go in it like visual or memory problems or fatigue, they're unseen, and therefore they don't get picked up as much, and therefore people are not offered so much treatment. I think the general principles of plasticity, changes in the brain that respond to particular types of training are still there, whether it's memory, whether it's moving, whether it's communicating. Vision is a tricky one. So sometimes when people lose half of their vision, you lose half of your vision in both of your eyes, the visual cortex at the back is probably one of the least plastic bits of the brain, so it doesn't change quite as much. But it can do. I mean, you're incredibly early. I mean, you're weeks down the line. So I would not be making any pronouncements about you at all. But this is a good example about do we target impairment? Do we have to get those visual fields back? Or do we say, at some point, you say, okay, well, maybe it's not coming back. Then what you do is you just train somebody behaviourally to just be a bit more attentive to the other side. And just by kind of getting into the habit of maybe using your head, you can scan the whole visual field and it stops being so much of a problem. Memory, I mean, I think you'll see improvements definitely over the next few months. But again, it's about engaging your cognitive system, engaging your memory. But you're right, where are you going to get that? It's all very well me saying that, but you can get home and go, yeah, but how do I do that? And that's kind of where you need the specialist advice and specialist knowledge. It doesn't mean they have to come in and see you every day for a long time, but you need to feel like you know what you're doing. So I think you do need to get a bit of advice on that.
On that piece of advice, I'd just like to take the opportunity to firstly thank Nick for an excellent presentation that really opened my eyes to things that I was absolutely blind to. So thank you so much for sharing your knowledge and your wisdom. It's been fantastic. I'd also just like to thank each and every one of you for attending tonight's Florey lecture. Like I said, it is a very important part of our calendar for the Faculty of Health and Medical Sciences, and it's so good to see such a wonderful, engaged crowd in the room this evening. So again, thank you so much for your attendance. There are some light refreshments that will be served at the outside in the foyer area, and you're very welcome to join us in some light refreshments at the end of this presentation. And again, finally, I'd just like to thank, again, such a wonderful really organisation from Josie Gray and for Charlie for providing support this evening. Again, please travel safe for those of you who are leaving us directly. And again, thank you so much for coming out to a fantastic lecture. And please once again join me in thanking Professor Ward for a fantastic presentation.